a man? Can I get a chance to talk to you? Cause you are fooling with a dead man's corpse, and you don't know what you do. So you say you have a lover, and you love her like no other. So you buy her diamond that someone has died. Oh, don't you think there's something wrong with this? Tell me, who's responsible for what we teach our children? Is it the internet or the stars on television? Why, oh, why, oh? Oh, so little Lucy turned 16, and like the movie she's been seeing, she has a lover in her daddy. She can't tell nobody till she met the evening news. For there is fire on the mountain, and there is nobody around. Oh, there is fire on a mountain top, and no one is around. Oh, yes. One day the river will overflow, and there'll be nowhere for us to go. And we will run, wishing we had put out the fire. Oh, there is fire on the mountain. No one is around. So yeah. There is fire in Africa. Oh, there's fire everywhere in the sea. Yeah, in the air. No one is surrounded. Fire. Yeah. Nobody is surrounded. Oh, Chumatimo, mi, Ilehio. Oh, Chumatimo, Morireo. Oh, Chumatimo, mi, Ilehio. Oh, Chumatimo, Morireo. Adaba, Adaba, Wabale mi o, ojúmọ́ ti mọ́, mo ríre o. Ojúmọ́ ti mọ́, ojúmọ́ ti mọ́ mi, nílẹ̀ yìí o. Ojúmọ́ ti mọ́, mo ríre o. Ojúmọ́ ti mọ́, ojúmọ́ ti mọ́ mi, nílẹ̀ yìí o. Ojúmọ́ ti mọ́, mo ríre o. Oh yeah, Adaba, ti fò lókè. Wá balẹ̀ mi o. Ojúmọ́ ti mọ́, mo ríre o. Oh yeah, Adaba, Just other day, the other day, I was talking to the weatherman about today. And all he could say was no one knows tomorrow. See, I can read the weather child, I can tell my beat it river for the sunshine. Well, that's as far as my guess goes, 'cause no one knows tomorrow. No one knows tomorrow.
No one free tell.
Time wasn't need to go to war. All the kidding just to settle someone else's score. But the future isn't even sure. No one knows tomorrow. So we can study history and philosophy and play sociology. But tomorrow's a mystery. No one knows tomorrow. No one knows tomorrow.
Worship.
Opportunity to fail or be successful if you please. Yes, indeed, tomorrow is a politician's today. He's the victim of the seasons and the victim of our children. So when I die someday, will I be in heavenly places singing hallelujah with an angel on the
What did you mean get that? Get that.
That's what I'm doing. Follow you for honey we will follow you for you wanna follow you for Sakina Amabuhina Waidi Ama Sakina Amabuhina
Hello.
Hi guys.
Hi.
May I see you?
Hello.
Hi.
Hello, Bimpe.
Hello.
Hello. I'm good.
Bimpe.
How are you?
Kúnlé bòní.
Mi ò rí Kúnlé o. Kúnlé fojú pamọ́ sí.
Alpha, báwo ni?
Let me see. She will iPhone. I'm going to change everybody's name to their real name.
You Alpha?
I do.
J1.
Pretty. Let me see pretty.
Joe, I can see you.
Alpha. Oh, serious? Oh, Alpha. How was the day today? We missed you.
Olalere, Charles. Shado Baba.
Joe, I can see you.
Yes, so Saza, Baba.
I can see you.
Baba.
I can't see this.
Oh, God.
Our teacher to call Yoruba. What did that not delete? Go, but they will change for do. They need to go and delete it from Yoruba syllabus. What is your dread, man? How are you?
Kola. Dr. Adebowale.
Now we cannot see your slides, so we are seeing your Zoom.
Dr. Tolu, data protection.
Abio.
Let me see pretty.
Yes.
Oh, yeah.
Oh, serious? Oh.
Let me see pretty.
Oh, serious?
Hello, Larry.
Jiminko. Alpha, only I can see you. See as you fast. This log that don't do you good. See as only pass. Child.
Too much money.
Okay. Olawale, Alpha. Kola, Alpha.
Kola, activate speaker. Go.
You want about only US? Pẹ̀lẹ́ ṣe ò tọ́jú ara ẹ ṣá.
Hello, whoa. Àdúrà ni kí a gbà kó a o.
Àbí gbà o. Ọlọ́run á gbàdúrà lórúkọ
Ọlọ́run
Jésù.
mọ́jà arógun kòrónà líbẹ̀.
Yẹ́mi sí.
Àìrí. Alpha.
Ojú rẹ̀
Yo,
rèé.
my sister. Fóònù.
Àṣẹ o.
Ṣé wàá pa?
Ìfẹ́ òṣèṣẹ́ ń jí.
Báyọ̀ o, ẹ̀yin lẹ jí mi láàárọ̀ mi.
Láàárọ̀ yóò okay. Pẹ̀lẹ́.
Mo ṣe ń jí ni mo fẹ́ ṣe coffee kí n lè wake up properly.
Èyà ọba fàdúrà jí ẹ, ó dá bẹ́ẹ̀.
Àbí lẹ́yìn àdúrà mo máa ń padà lọ sùn.
Ó bẹ́ẹ̀ yẹ
Ọkọ̀ lórí ìgbà yìí o.
Ọkùnrin
àwọn màámi ti dé. Màámi akíní o.
Èso ni bébì, àrí bébì omi ké.
Mo ṣe rò pé bébí ẹ nì, ta ló ní bébí ẹ? Mi ò rò pé bébí ẹ nì.
Jí tíyẹn bá jí ẹ rí, ló ń dá kó ráyè. Ẹ rí ó máa make sure fóun ló ń tẹ́ kó bá mi ti èèyàn.
Mo ṣe rò pé yẹn nì.
Abẹ́lẹ̀ ọmọ kékeré yẹn ṣe.
Ẹ jọ̀ọ́ ta ni Jones? Who is Jones? Mo wo Jones iPhone, right?
J1.
Oh,
Okay,
that is
J1.
true.
Ṣé wọ́n ò tún kọ́ fóònù ara ẹ̀?
Ó ti disconnect.
Pẹ̀lẹ́.
Mi ò rò pé mi ṣe òkè.
Tani Jones iPhone. J1.
J1, he said the iPhone, that big boy now.
It cannot be. But it's a mistake. You remove any yellow. It cannot be my iPhone. Put your any The person
There's someone who get Jones. Can you see the person?
I can't see the person anymore. The person is not sharing.
I think it's J1.
I think
J1 said it's not J1 now. So it has to be something apart from J1.
Then who is iPhone? I don't come for iPhone.
You are shouting.
Janet.
Okay, GTO.
There's so many people here.
Yeah, there's so many people. And when are we going to start, guys?
Being Turu, ayé òsàlọ, Corona ló ń pa àwọn èèyàn.
Ìfẹ́ òbọ̀ data jó Nàìjíríà ní kí ló bá lè
Àbí òjò.
Ẹ kí everybody, ayé ò parẹ́ rárá.
Ṣáájú wa o.
Ó sì ní ilẹ̀ rí kí ayé.
Ọ̀gẹ́ data jó Nàìjíríà ní.
J1 to join again.
Kí ló ní J1 fi ṣe yẹn fi J1 oní J1 lẹ̀?
Jones to join.
Jones, you are welcome to our midst. Let's continue. Àbí èwo wàhálà Jones.
Àbí o, mo ṣàdúró ara wa náà ni.
Thank you very much.
Báwo kàn tiẹ̀ ṣaláríà?
Dr. Akinola, please F5 on your computer.
Tani o ṣara yín o.
Kúlẹ̀ ọ̀gá, ó ti ẹ̀rọ ti pàdé ẹ̀ ọ̀gá. Ó ti ẹ̀ bèrè bí. Kí ló fẹ́ sọ?
Kúnlé pẹ̀lẹ́.
Kí ló fẹ́ sọ?
Mo wà ní lọ́gà. Àwọn tó pọ̀ lẹ́yìn Dr. Adebowale.
Okay.
Today was the problem. Why are you doing like this today?
Bí bẹ́ẹ̀ni àgbàjọ kan. Àgbàjọ.
Our prayer coordinator. Our prayer coordinator.
Thank you. President.
Excuse me.
Dr. Jimmy.
Emilio.
Elizabeth.
Manuel Okon is watching on YouTube and he says hi. We have 3 people watching on YouTube.
This is better.
Hey guys. Do we have a moderator? I think
Dr. Your captain.
Have that much time.
Your captain.
Okay.
After that, names of noise makers.
Don't you see his
names of noise makers in this place?
Please, if you are not presenting, put your microphone on mute.
Okay.
And Juwo can do that. Juwo can mute everybody.
Okay.
Let the moderator
So, Juwo, please. Thank you very much, everybody.
Okay.
We are those making noise about the end now, huh?
Kunle is also muted. Can you unmute Kunle? We can't hear you.
Only we cannot hear you.
Because you want to mute everybody.
What's your mute? I have unmuted.
So who is moderating this session?
I am. Okay, can you hear me now?
Yes, we can.
I can hear you now.
All right, good. Super. So guys, thank you very much for coming on board. And thanks for finding the time to do this. Incidentally, it's our first time, but we hope to make the best of today. I think this idea, first and foremost, I need to give credit to a few guys. I want to give credit to Dr. Folajimi. I think the idea came out of one of those informal conversations we used to have, and I will still do anyway. And somehow we try to crystallize it into something big and something laudable. The whole idea is to, first and foremost, get to see ourselves, get to socialize on a more, multimedia or audio-visual level, get to add faces to people's names. Some people have changed. For instance, the one was one Lepa boy when we were in school. We all can see that he has added some palms. So, and then we know people that haven't really changed. People like Pinkwe haven't really changed. Ever got elegant and slim as always. People like myself haven't really changed as well, except that I have hair, a lot of hair on my head now to compensate for my height. Okay, so please, guys, when we log on, let's always show our faces and let's take the opportunity of this platform to socialize and actually enjoy ourselves. Today, we'll be at the instance of Dr. Jimmy and Dr. Akinola. They'll be taking us through a lot of things. Jimmy shared some of those things with me earlier today when we had a dry run on the platform just to test the mechanism and all. And I think we're up for a very great time. So a round of applause for both Dr. Akinola and Dr. Adebowale for making it time today. So Jimmy, I know you guys have your own way of running this. So guys, I think we can start. We should be able to do this in 45 minutes. Thank you very much. God bless.
I want to go there. One side.
Wait, so you want it muted or not?
Yes. Dr. Akinola will take the first topic. We are going to run through 6 topics. So we alternate between me and Dr. Akinola. He has 10 minutes for every topic that we'll take. So he'll take the first topic. I'll take the second one. He'll take the more than 4 minutes. So Dr. Akinola, you have the floor. I think about 6, 7, 8. Yes. No, don't take it that far, please. Don't take it that far. Hello. I think Dr. Akinola has been muted. Tolu, can you hear me? You have the floor. Hello, Tolu, can you hear me? Hello?
Maybe his mic is muted. Doctor,
let me call him.
I think his mic is muted.
So I can't unmute him because he has to unmute himself. Okay. Yeah, Tolu, you have the floor now. I can hear everybody. Okay, cool. So you can start now. Well, I can't hear you from the laptop now. Tell him to unmute his laptop. To unmute his mic on the laptop. On the left corner, you need to unmute your mic. Mute. The left lower corner, you see the mute icon there. So you unmute your mic. Have you seen it? Hello? I think I've done that. Okay. Have you been able to unmute your mic in the left lower corner?
Hi, guys.
Hello? Hello? Yeah, have you unmute your mic in the left lower corner? Yeah, it's like the network is updating here. Oh. Okay, so Jimmy, why don't you place your cell phone really, really close to your laptop? I think we may be able to just although over get credit to Dr. Over get credit to over get credit here. Or let me take the first topic then. Tolu. Yeah, maybe I should take the first topic then. So by the time I'm done, you will be set with the. I'm sure the network will be better by then. Okay. So can you exit the screen? So let me come on with diabetes. Okay, I'll stop his share screen and then you can share your own screen. Okay. Okay, so let me see what I have here.
Something in your mouth.
Everything is blank.
Let me see. Full screen. All right. So, hello everyone. You have to share your screen, though. You haven't shared your screen yet. I'm about doing so right away. Sorry. Yes, okay. All right. I'm sharing this screen. I hope everyone can see it. Hello? Good. Yes, we can see your screen now. So can I start? Yes. Okay, good. All right, thank you, everybody. So Tolu's having a bit of a network issue. So he's supposed to start off the floor with hypertension, which I would have loved to have as a first topic, but it was coming up next. But along with that, let's talk about diabetes for just about 10 minutes. This is 4:20. By 4:30, I should be done. Now, we've all heard about diabetes. We all know what diabetes is, but let me just say a few that I consider very important based on my experience on diabetes. Now, by basic definition, diabetes is a disease that affects your body's ability to produce or use insulin. Insulin is a hormone created by the pancreas, and what it basically does is that it helps us drive blood glucose into the cells. The absence of insulin leads to what we call starving in the place of plenty. The cells need glucose. Glucose is surrounding them, but they don't have it. The symptoms are very basic: frequent urination, frequent thirst, and frequent hunger. These are the very basic tests of diabetes. When someone complains of frequent urinating overnight, you don't expect, so I do expect someone to urinate possibly 1 or 2 times, but when someone is complaining of urinating 4 times, 5 times, 6 times, to the point that it's actually interrupting the sleep, it is high time the person has to check his or her blood sugar. Now, when we talk about checking blood sugar, there are several means of ways to go about it. The first one has to do with I hope you are seeing my slides as I'm changing them.
Yes.
Yes.
Okay. Good. So now there are several tests that you could run for blood sugar. You could run what they call the random blood sugar test. You could do what we call the fasting blood sugar test. You could do what we call the oral glucose tolerance test. And lastly, you could do what we call the glycated hemoglobin A1C test. Now, there are different reasons for each one of them. Now, imagine the clinics, they're watching an elderly man in the afternoon, a known diabetic, or possibly an unknown diabetic. You check suddenly around 2 or 3 p.m. and the blood sugar is reading 350. Clearly, right there and then, I will assume that that person is diabetic. I've never seen him before. I've never had a check before. I would have loved to do that check before he had eaten in the morning, but right now it's an emergency. We don't have that luxury. So it's clearly an elevated blood sugar situation. But the most ideal thing for the average person is to do a fasting blood sugar in the morning. That is before you eat in the morning. And that is prior to a 12-hour fast, like from 8 p.m. in the night to 8 a.m. in the morning. Preferably you don't drink, but if you have to drink, fine. But preferably you do not drink water. Now, the oral glucose tolerance test is what we usually do for women who could possibly be diabetic. Now, before I go further, there are different types of diabetes. There's type 1, there's type 2, there's gestational, and there's a group of other several ones that are really not common. The one we will focus on majorly is type 2 because that is where majority of people lie in. Type 1 is not so common as with type 2. Gestational diabetes is the diabetes or hypoglycemia that occurs in pregnancy. I hope I'm not running too fast. Hello, everyone.
I think you're good.
Okay, good. So gestational has to do with pregnancy. It wasn't there before, it showed up in pregnancy, and in most cases, it will revert back to normal after pregnancy. However, the individual still stands a very huge risk of developing diabetes later in the future, even in the absence of pregnancy. Now, we need to have some criteria for screening the general public. Oh, sorry, it said my internet connection is unstable. Oops, I need to, let me switch briefly, please. Yes, hello, am I with everyone?
Yes, yes.
Good. Now, we have a criteria for screening. Now, generally, we like to screen everybody. Some people use the age of 40, some people use the age of 45 as a cutoff criteria, depending on the scenario. But I think 40 is more comforting. Another criteria is if anybody has some risk factors, it's better to screen that person at any point in time. It might be 25-year-old, it might be 20-year-old, it might be 30-year-old. If there's a pre-existing risk factor in that person's life, it's best to screen that person. So the glycated hemoglobin A1C test is also done to actually assess the blood sugar, but it's more sensitive, and this is where I like to explain it. Imagine you run, I like to use what we call a continuous assessment of 3 months to explain the glycated hemoglobin. And the reason is this: you check your blood sugar every single day, or every other day. You get fluctuation. Today is 100, tomorrow is 90, tomorrow is 120. The glycated hemoglobin test will give you a good idea of how you've been doing in the last 3 months or in the last 6 months. Okay, so it's like a scorecard for a long period of time, not just for just one day. I hope you get my point. So let's go to the next slide. Now, over in this slide, I'm trying to, I don't want to bore you with facts, but there are certain limits we need to understand when we are checking the blood sugar. The first thing you need to know is that there are usually 2 units we use. There's the millimole per liter unit, and there's the, I think the gram per mole unit. One unit has to do with numbers around to like 90, 100, 140, 150, which whenever you hold a glucometer is what you will most likely see. The other group of units that we use actually have a lower number. You see 5.6, you see 7.1, you see 11, you see 12. So you can actually calibrate your glucometer in each one of those categories. They are usually different. For example, now you could see 100. In another unit, 100 stands for 5.6. Okay, so you need to understand that fact. more often than not, most people here in Nigeria actually use the grandpa DL unit. That's the grandpa destinator, which rates in like 90, 100, 150, 200, 300. We hardly ever see people using the 5.6, 7.8 unit, but just in case you come across that, so that we won't get confused. Now, also another thing you need to know is that from area to area, there's little moderations or little changes in those values. For example, now, some people will tell you that, oh, the fasting blood sugar for a normal person should be less than 5.6. Some will say between 2.5 to 5.6. Less than 2.5 is most likely hypoglycemia. The person will most likely be feeling dizzy, be feeling weak, and having all those symptoms of low blood sugar. But beyond 5.6 might be something else. Now, there's another category we need to understand, which is very important, which I really think I need to press on in today's meeting, is the pre-diabetic category. These are the people that are not normal. At the same time, they are not yet diabetic. But the fact is that in the next 5 years or 10 years, they will be diabetic. Now, majority, or at least the good populations are last standing, about half of the US population right now are pre-diabetic. That means they are not yet diabetic, but they have a poor way of handling sugar. So we consider them to be pre-diabetic. This same category, this same way of categorizing them also exists in hypertension. Some people are not yet hypertensive, but you call them pre-hypertensive, which means that sooner or later, if care is not taken, they will become diabetic, or they will have such issues. So we have that category also running between 100 to 125 or 5.6 to 6.9. Then we have those who are above 126, or in some cases above 7, which is considered to be clearly diabetic. So that is the category for the fasting blood sugar or fasting plasma glucose. We have it for HbA1c2, and some people use less than 5.7 to be normal, 5.7 or so to 6.4 to be pre-diabetic, and above that to be above that level, which is 6.5, to be actually a clear case of someone being diabetic. So if we go over to the next slide from here, we're talking about the risk factors of diabetes. Now, the risk factors are reasons why the person will most likely be diabetic. Now, you could meet someone who is not yet diabetic, but if they have this risk factor, some people will even tell you that if they have 3 or more of these risk factors, they will most likely be diabetic in the future. And this is where I think we really need to be focused on. And the reason is this: at this point in time in our lives, we find ourselves in a category of, in a place where we tend to take care of older people and we tend to take care of younger people. You may not take care of them directly, but you could be involved financially, or you could be involved physically in their care. So it's also very important that your knowledge level about their situation should be at a very good point, so that you can actually make informed decisions. We've had a lot of controversy concerning the care of diabetes. We've had people messing up their medication, people messing up their care, people abandoning their care based on misinformation, based on ignorance. So it's important that the average person should be health literate in this issue, because either directly or indirectly, you may find yourself in the category of making a decision for somebody who is diabetic. So the risk factors are these: people above the age of 40, which is why I prefer screening for everyone above the age of 40. Inactive lifestyle, that is a sedentary lifestyle, possibly a lifestyle in which you drive to the office every day, then you sit down at the desk all day, and you drive back home, and you sit down to watch TV, and you sleep, and you wake up and continue that cycle day in and day out. This is a sedentary lifestyle, and it's also a risk factor for diabetes. High blood pressure is another risk factor for diabetes. High blood pressure and diabetes are like 5 and 6. The diabetic population have a very high risk of developing hypertension later on in life than the general population. Gestational diabetes: any pregnant woman that develops diabetes, or anybody that has a history of diabetes in pregnancy, has a tendency to develop diabetes later on in life. One of the reasons we have diabetes sometime in pregnant women is women that have very large babies. I'm talking about 4.5 kg, 5 kg babies. Such babies are usually born to diabetic mothers. Now, another risk factor is the impaired glucose tolerance. The impaired glucose tolerance is the pre-diabetic category I mentioned earlier. The value is not comforting, but it's not yet bad. It's between 5.6 and 6.9. To make it easy for anybody, you could just say between 5 and 7. Okay, that's the pre-diabetic category. So anybody in that category, there's going to be, I consider that a risk factor. Abnormal blood lipid level. Lipid level has to do with your cholesterol level. Okay, so abnormality in the cholesterol level is also a risk factor. BMI of more than 23 kg, those are for people who are really, really on the big side. Okay, and lastly, family history. A family history of diabetes is a very, very strong risk factor. Now, we can actually categorize our risk factor into two things. There are certain things you can change, and there are certain things you can't do anything about. If you have a family history of diabetes, you can't do anything about it. Okay? If you have 40 years and above, you can't grow younger, you can't do anything about it. If you've been having gestational diabetes in pregnancy, you really can't do anything about it. If you have any other medical condition that will predispose you to diabetes, you really can't do anything about it. However, there are some of these risk factors that you can actually do something about. Now, doing something about them is actually you being able to reverse the situation. Because if by now someone is pre-diabetic, he'll still be going up and down. There's no symptom at this point in time, okay? But if he's on the big side, if he has a low activity level, if his blood pressure is on the high side or the cholesterol is on the high side, these 4 factors can be reversed, they can be changed, and this will result in the person moving from pre-diabetic to being normal or a normal fasting plasma glucose level, okay? So we should be able to know that there are some factors we can't change, and there are some factors that, yes, we can improve of them to actually reverse the situation back. And that is the beauty of knowledge in this category, because if you've been screened and you are pre-diabetic, you can begin to work on it and avoid all the complications that come with diabetes later on in life. So now this is a little data. I hope you can all see my slide as I'm changing them.
Yes, we can.
Okay, cool. This is a little data that's talking about the situation of pre-diabetes in the US. 84.1 million American adults, more than 1 out of 3 people have pre-diabetes. It's roughly about half right now. Okay, so it's, and you know, we more or less are following the Western lifestyle in terms of our eating pattern, our sleeping pattern. So this kind of situation are called non-communicable diseases. These are prevalent much more in developed countries and are now emerging to be a big issue in developing countries too. So we are having to see more diabetic people, we're having to see more hypertensive people, and we are now seeing them in Nigeria at a lower age situation, much more than before. You've seen diabetes as low as 24 years old, 25 years old, severe hypertension in 30-year-old with chronic renal kidney failure. So we are more or less inheriting the issues of the West. So now this is a slide that's talking about the common risk factor. We mentioned it earlier, reducing your risk factor, and I've talked about the 4 things earlier on that you could actually do something about and change. So, and this also expands it further. Non-modifiable risk factors are factors that you can't do anything about, and the modifiable ones are something you can do something about. Once again, let me reiterate them: physical inactivity, high body weight or body fat, high blood pressure, and high cholesterol. These are things we can do something about and make changes in. Now, one of the problems with diabetes, apart from the blood sugar, are the complications that result at the end of the day from prolonged, uncontrolled diabetes. There's what we call hypoglycemia unawareness. Now, this is a problem. We do know that in most cases, if you are not eating in a long time, okay, there's a tendency that you may begin to sweat, you may begin to shake, you may begin to have little tremors, sweating heavily, in which you just want to take a bottle of soft drink or take something immediately to calm the situation. And we do know, if you have experience with people that take care of diabetic people, that we tell them to take their medications when they're about to eat, so that they try to avoid a situation of hypoglycemia, in which they feel all the symptoms of low blood pressure and they quickly take something to correct it. But one of the problems that may arise in some people is that blood sugar will crash, they will have no symptom, they'll be feeling fine 1 minute, and the next minute they slip into coma. Okay, so we've had a case in which an elderly man refused to eat, and he went to take his medications, and he went to sit outside trying to read papers, and the next thing he was on the floor. He didn't shout, scream, or do anything. He just slipped into coma. There was no sign earlier on about it. Okay, now we all know the story of a loss of a toe, a foot, or a leg. Amputation or loss of a toe is a big deal when it comes to diabetes, because one of the complications is what we call diabetic neuropathy or peripheral nerves, in which they lose sensitivity of the feet. I've had cases of diabetic people who begin to lose sensitivity, and they have issues while driving, because when they are pressing down on the accelerator, they are not sure, or the brake, they are not sure how much they are pressing down, because the legs are practically sort of dead. The sensitivity in the legs are dead. When they are touching it, when they are not touching it, they lose sensitivity and all those things. These are signs of poorly controlled diabetes, and these are signs that occur over a long period of time. Now, another major problem with diabetes, big issue, is that it lowers immunity. There's what we call in medicine lazy leukocyte syndrome. It lowers immunity and it predisposes them to more diseases. For example, now in the current ongoing corona pandemic, people with diabetes have lower immunity, just like people with HIV, and they are predisposed to much issues here because their immunity can't fight infection. So they are prone to have more infections in other places. They could have oral thrush, urinary tract infection, so many issues that we've known before. Sharp drops in blood pressure. Now, one thing most people do not realize is that the kidney plays a big role in blood pressure and in blood level. Okay, so when the diabetes has an issue, it's one of the organs that fails here also is the kidney. So when you have kidney issues, which has to do with, okay, what kidney issues, kidney damage, you have high blood pressure. If they are not eating well and some other issue comes in, they could have very, very low hypertension along with the low blood sugar along the line. Oh, I'm mixing those facts up. The blood pressure we are talking about here is due to the low blood sugar and they go into shock. Another situation is because they have diabetes, they have kidney damage, and BP becomes uncontrolled. Digestive problems, sexual dysfunction. Now, erectile dysfunction is a big deal when it comes to diabetes. Most diabetic patients end up experiencing erectile dysfunction just the same way they have issues with their leg, they have issues with their reproductive organs too. Increase or decreased sweating. This one also occurs in them also. Next slide. So now let's talk about management. We've talked about everything so far. So how do we control this thing? Now, up till now, we still believe that diabetes cannot be cured. There's been so many arguments back and forth in this area. Some people believe herbal drugs can cure it. Some people have believed in different directions. There'll be different propositions to it. Some people, even in the US, have talked about plant-based diets being able to reverse blood sugar level, even to the point of reversing the complications of diabetes also. But the problem is that most of all these claims have not been done in a wide population, in a large population. So we're having just little claims left, right, and center, and it works for some people, it doesn't work for some other people. So it's very hard to put your feet down and say diabetes has been cured or can be cured. But everything still has some element. The second thing I'd like to mention is that when we talk about diet in diabetes right now, there's really no, and from fact I have is that you don't really sit on any issue and say, don't eat this, don't eat that, don't eat this, don't eat that, that we used to know. When we talk about people eating beans, beans is 80% starch. So if you're saying that, oh, beans has protein, they should eat more of beans, they shouldn't eat any other thing, then you could run into problem in the future with that. But one thing that has really been a fact is that portion control and balance, plenty of vegetable, okay, a very improved diet will go a long way in achieving a very good blood sugar control. Okay, we try not to rule out anything in what they eat, but you can limit it. And at the same time, also, most diabetic people might end up having depression because it's a chronic illness. Chronic illness usually has a relationship with depression. So you'd want to try as much as possible to cheer them up, let them live a normal lifestyle as possible. So that's where the issue of the food comes in. You try to mix their food in such a way that they don't feel left out, they don't feel neglected, but at the same time, they don't harm themselves. Okay, so they have to go to an improved diet, possibly see a dietitian, and see how they can work their meal out from day to day. Regular exercises is another thing. Now, if you look at what I have here as management, weight loss is very, very important. Healthy eating comes in next. Regular exercise, 30 minutes brisk walking daily, okay? They will be on medication more often than not, especially when you've confirmed it's a case of clear-cut diabetes. They will be on drugs. But however, for certain reasons, you may look like, okay, should it be drugs or should it be insulin? Either one. And then you talk about blood sugar monitoring. Now, bariatric surgery is actually there also for those who are morbidly obese. They are so big, and there's little motivation to lose weight because they have a very huge appetite. So you begin to wonder, how do you control this weight loss? You see these programs on TV when they show someone who's like 300 pounds, like that's like 200 kg, or more than even 300 pounds, 400 pounds, some very, very crazy weight. There's really nothing much you can do for them in weight loss. So bariatric surgery comes into place, and it's basically about surgery in which they reduce the size of the stomach. Okay, so there's early satiety eventually when they go back to eat, there's early satiety. They eat little food and they are filled up for a long time. So that is how one of the ways you help to control diabetes. So because bariatric surgery will lead us to weight loss, and with the weight loss, there's improved blood sugar control. Now, there are some other things we mentioned there also, lifestyle, home, and remedies. Now, in the management of diabetes these days, we try to encourage the patient and work with the patient because a lot of the success of the treatment depends on the patient. So you need to put in more effort and more time to discuss with the patient. And more often than not, it is very important that you don't allow the patient to come alone for clinic. Possibly they come with a relative, their son, their wife, their daughter. Someone should come along with whenever an elderly person goes for their diabetic clinic, someone should come along because they may or may not mix up the medication the doctor has written. They may or may not mix up the advice the doctor has given, okay? So somebody has to be there. So there's a lot to be done by the family who is supporting the diabetic person. More often, we're talking about the elderly in this case. They should not be left alone to hear what the doctor said or make decisions in that regard. At the same time, they should be supported in the house to be able to achieve the lifestyle and home remedies adjustments, which will help them, take their health to the next level and prolong their existence. Okay, so I'm about to round up. I've spent much more time than I planned. I got carried away with that. So lastly, let's just talk about in pregnancy, changes have to be made. Also, signs of trouble are when the blood sugar can't be controlled. And I mentioned some very medical words here. These 2-year actually medical emergencies that result from diabetes. So that will be all for now. Thank you, everybody. I've gone beyond my time. Like I've used double of the time I planned.
All right, doctor. Thanks.
That was very good, though. Wow. I hope it didn't sound as if I was rapping because I was trying to.
No, you were speaking to us like we are medical students, but we understand.
Well, I have a couple questions. Okay. So, quick one. You mentioned food. I mean, I remember, like you said, they used to tell us, don't eat too much starch or eat protein. That's how you reduce your what's the word now? Vulnerability to diabetes. And now you've said even beans is really not. And we do know that most of what we eat in Nigeria, in Yoruba culture, is all carbohydrate. Everything that comes from cassava, for instance, fufu, gari, amala, eba, rice. That's olori onjewa issue, So what food do you recommend? How would you recommend eating? That's number one. Number two, is it that we don't have data for Nigeria? Because I see that all the data you presented was US, and most of us live in Nigeria. So What are the numbers like, especially in our age range in Nigeria? And then lastly, is it that Yoruba language is not a good medium to communicate medical issues? So these are my 3 questions.
You are freaking kidding me.
Okay, quick one. The first question, you see, when it comes to food and diabetes, there's so much controversy. There's a movement in the US and over here that will tell you that, oh, plant-based diet will reverse diabetes. They won't use the word cure, it will reverse diabetes. Some people will say that, oh, fat is the only thing that doesn't even elevate the blood sugar when you eat it. But what is really safest is that, first of all, work with a dietitian. Second of all, make sure that the majority of your food still falls in the range of the vegetables. Okay, minimize on red meat. If possibly, say no to red meat. Okay, carbohydrate to a good extent, because you see, at the same time, you must look at the psychology of your patient when they are eating too. That psychologically they must be pleased with what they are eating. They must accept that this is the best thing for me. This is good for me. Do you understand? And they must go along with it. I've not mentioned the issue of smoking and drinking, which should totally be eliminated because they make matters worse.
Eliminate it. What's your own?
Now, concerning data, there are data. There's been certain research in Nigeria, which I've not made reference to. Okay, but I can tell you that it is a big deal over here also. And I chose to use the US data because our population is growing. We are westernizing the more, and we are more or less heading in that direction. Okay, so we have a problem. We have a problem when it comes to infectious diseases in this part of the world, and we have an emerging problem from non-communicable diseases also. Thirdly, concerning the Yoruba, I can get you my WAEC result from SSC. You won't believe I had F9 in Yoruba.
How can you have F9 Yoruba?
Signed by Mr. Gubiade. I can produce that result for you. I don't know if Tolu and Tunde can remember, but to buy a Yoruba in one year, fa.
Okay.
All right, so Tolu, let's quickly take you up on this other. We'll still take more questions before we close, but I want Tolu to run up on diabetes, and he's been more academic.
Sorry, I just have. I don't know if you guys are hearing me.
I can hear you.
Hello.
We can hear you.
Oh, so you about sedentary work.
Hello.
Sorry, go ahead, Tunde.
Okay, so while talking about the sedentary work nature, it is advisable for people who work and sit down a lot to use a sit-to-stand table. Not necessarily a sit-to-stand table, but there are devices that you can attach your workstation, can be structured around where you can move your display screen up and then stand to work. It helps a lot. It's when you can stand like 80% of the time. For those who are a little bit fat like us, it helps seriously. But then another factor is if you work in a place where they are not going to provide it, it is advisable to get it yourself. And if you can maybe tell them, recommend for them to do it, it's a very good thing. It helps a lot, seriously. It helps our health. Thank you.
Yes. Now, in that regard, let me quickly chip in. The problem on the sedentary lifestyle is not an individual problem. It is a policy problem in most cases, because the way the society is structured, it doesn't help you not to be sedentary. You have to drive. You have to. If you are in the capacity to push policies that will help communities and help their work environment, possibly have a gym in the office. Some offices have crèche in their offices, which is helpful for their young for nursing mothers in that place. But if your office has a little place where you can work out, or you can push your such solutions, it's going to be fantastic. Also, so if you're looking for solutions when it comes to sedentary lifestyle, I advise you push for much more for policies that affect the work environment and provide this thing more easily. It's easier that way than one individual trying to do his own thing, but at the same time, do your own thing too. That's very helpful. All right. So time is 4:51. Tolu, would you like to come on board now? Hello.
Please, if you're not asking a question, please just mute your microphone because I'm muting some people and you keep on muting and then we are getting a lot of feedback. Please, if I mute you and you're not asking a question, just stay muted.
Jiwon, can you please unmute Dr. Tolu? Is still muted, so we can't hear him.
I don't even see Dr. Tolu on the call. Okay. So I cannot unmute Dr. Tolu because it's not unmuting when I click on mute. I think he needs to unmute from his own computer. Let me...
Dr. Tolu, can you please chat your technology issues and we'll see if we can remotely solve it.
Let me call Dr. Tolu. I think I can.
Or he can chat. If he can post what the technology issue is on the chat, then we can see if it can be remotely resolved.
I'm a dodbon sikini. Odon tolaye kawa losoro. Kí ló ṣe Bukky Olúbẹ̀kú tó ju ọ́bí politician tó ń campaign? So camp. Hold on, doctor.
Yeah. I don't know. Is anybody here to look? I hear you now, Tolu.
Can you guys hear Tolu?
Yeah.
Everybody
is muted already.
Call.
Almost everybody is muted.
Call Tolu. So maybe you can talk on the cell phone and then you guys can hear. Yeah, can you guys hear Tolu? Yes. Hello, I can hear you.
Juwon?
Yes.
Juwon, sorry. We can hear him now. It's not very clear. But to follow what he's going to be saying, is there a way he can send you his presentation? You present and he talks.
Amazing. Hello, Advijo. Yeah, I can hear you. I can hear you clearly. So they say that if you share your screen, I will be your Oshoyin. So you talk to me and I'll talk to the group. Does that work?
Hello? Juwon, if Dr. Jimmy has the presentation, we can take it.
Okay. I can take, okay, hold on.
While we wait for Dr. Tolu to be ready, Brother Bukky.
Hello.
Most of these things don't solve the size, weight, and all that. You don't apply.
Email. Sorry.
What thing exactly? The size, the weight, most of the things. Which other thing also to project power will apply? Gbogbo nǹkan tí Dr. Jimiko ẹ̀ ń sì pé ká máa ṣó nǹkan tá à ń jẹ. Sápẹ́ gádì náà bí jẹ ńlá wà jẹ́jẹ́ tí if test fún wa ní apple jẹ kò ní sí nǹkan tó jẹ́ pé high blood pressure kò ní sí diabetes kò ní sí pé kìíní o apple ọsàn ìbẹ́pẹ ìrèké nǹkan tá a máa jẹ.
So what is stopping you from eating apple ọsàn àti ìbẹ́pẹ now? Well, Talo Jutiti.
Veggies.
Jimmy, on radio, my jet, but my jet.
Eyes are something else.
So it doesn't matter.
Meanwhile, I have a question, by the way. Dr. Jimmy, you try and speak Yoruba actually. But try. So, Dr. Jimmy, you did not actually give us data in our age range. I would have loved something that addresses us, like the peculiar age group from 40 to like 50. Now you talked about, inheriting this, which like you said, we cannot, there's no way you can avoid, if it's passed on to you genetically. But I know you talked about lifestyle and all that. Now, there is a school of thought that said, even if you're not genetically wired to inherit diabetes, your diet could actually make you be diabetic. How true is that? Because people say don't eat sugar. Some people eat sugar, get away with it.
Okay, this is where it's wrong. Remember, say once, and never say never. Never say something can never happen.
There's so much noise, though. I'm muted.
Okay.
But not in Shesoji.
Charles.
One Shesoji because.
Okay, so now this is it. By virtue of our age, because most of us are in our 40s now, that is one risk factor. You understand? That is one risk factor. And it's not every, this thing is like this, 50% inherited, 50% lifestyle and environment. If you have 50% inherited and you have a fantastic lifestyle and environment, nothing will do you. You are good. Do you understand? However, if you have a kind of lifestyle that is very, very not healthy, that is very, very city-like and stressful-like, and you hit all you want to do and you go through all you want to do, and if you go through such a lifestyle, even though you don't even have the inherited factor, you may end up with diabetes. There could be a case in which there's nobody in your family that has ever been diabetic, and that person has been diabetic. Now, remember I said one thing, that there's type 1 and type 2. Our category here falls in type 2. That is the kind of diabetes where the insulin production in the body is reduced, and there's a lot of insulin insufficiency. In type 1, which is from birth, there's no insulin at all. Those ones occur from birth. And apart from gestation, there are some other types, like maturity onset diabetes and some other issues. Due to one disease, due to one issue, some people may just become diabetic. Do you get my point? So our age predisposes us, and this topic is because we are in that age category. Do you understand? And like I said, the best thing is identify your risk factors, go for screening, at least once in 6 months or once in a year. Check your blood sugar. If you are within the group, great. Now, the diet issue I mentioned applies more to those who are diabetic, not to those who are not diabetic. You get, so when Buki said Majeba, as long as you are not diabetic, you are free to go where you want to go, eat what you want to eat. To reasonable, moderate, responsible extent. So I think with that, I think I've answered your question, Abby.
Yes, you do. Thank you.
All right. So are we ready to take up the next topic? Has Tolu sent you the slides?
Yeah, he's sending it to me now. I'm waiting for Kuti Wale.
Okay. In that case, did I just take the second topic on my slide?
I think so, to save time.
Before you take the second topic, please. Sorry, I have a question.
Okay.
So, you know that fruits and vegetables are not accessible in some areas. I don't want to appear as if I'm not in touch with realities here. But, so what are the alternatives that people can use? Are there supplements in the market? Are there any other thing that people could eat to make sure that we have balanced diet and we are not exposed to diabetes as we grow older?
Okay. I don't want to sit on the premise that fruits may not be available all year round, but vegetables and some how do I explain it? Some basic meals can be planned out, and you can because if one is not careful and you say it's not available and that is not available, you may find out you are just eating junk for the rest of the week and for the rest of the days based on that inavailability and unavailable situation. And that is why I propose that in most cases you need to sit with a diet and know what is available and find out what you can work with in that case. Like I said,
Dr. Tolu says there's a huge network problem where he is. So Dr. Jimmy can continue with the next session while we figure out this issue.
All right. So let's let's go to the next slide. So the question is, what if some things are not available? How then do you eat? Like I said, the bar has really been, I don't know how to explain this. It's about quantity more than even what else you are eating. But the advice is like plan your meals out, make it moderate, especially for those on the big side. And I thought they'll be fine. And I do know one or two doctors who have actually said they've done research studies and placed people on plant-based diet. Now, plant-based diet is more or less saying a vegetarian diet. And they were able to control blood sugar on that. Because the belief is this, what they said as the belief is this, the major problem is not the glucose. The major problem is that the cell is unable to absorb the glucose. So the sugar is not exactly the problem. The problem is that the cell is not taking up that thing due to one or two other factors. If do you get my point? Hello?
Bimpe asked you the question, but yes, I do get your question. Thank you.
Bimpe, thank you. Okay, so let's take on the next topic here.
You will need to share your screen again, because you're not sharing right now.
Okay.
We are raising up hand.
Okay. Baba.
Dr. Jimmy.
Yes, I'm with you.
Hello, Dr. Jimmy.
Hello, yes, I'm
Please,
with
when
you.
do we consider it a low blood sugar? You said anything less than 100, anybody who has less than 100 is not diabetic. So what exactly will be the reading for low blood sugar?
Some people use preferably between 60 and 100, sometimes between 70 and 100. Below 60 or below 70 is considered low blood sugar. But the major thing about that low blood sugar is that there's actually symptoms of low blood sugar: tiredness, dizziness, sudden outbreak of sweat, possibly these are signs of low blood sugar. So you might not even be able to check at that point in time, but if you see someone who is diabetic suddenly breaking out in sweat, complaining of dizziness, complaining of yes, and you ask them that are they taking their drug, and tell you yes, they're taking their drug. At that point in time, there's a higher possibility that the situation is of more of low blood sugar than a situation of high blood sugar. Okay? All right.
Hello, Dr. Jimmy.
Thank you,
Hello,
Doctor.
Dr. Jimmy. Hello.
Yes.
Hello, Dr. Jimmy.
Hello, I can hear you.
Yeah, good evening, everybody. My name is Goke Adefalu. Please, I heard you talking about absorption level of certain foods into the system. I don't know whether I heard you right or not. Are there food or are there specific vegetables or food that one can be taken that can aid absorption of other nutrients into the blood system to that will help in enhancing the reduction of blood sugar in one system. Do you get my point, my question?
Please, can you? I get it, but I would love if you can come again, so I'll really be clear.
Is there a particular nutrient? Is there a particular vegetable or a particular food that one can be taken that can aid the absorption of necessary nutrients that someone needs to fight the blood sugar level in one's body?
Okay. Okay, this is it. I'm not aware of any food that aids blood sugar absorption. Like I said, certain thing is basic. We have glucose in the bloodstream, plenty of glucose based on what you've eaten. This glucose is meant to go up into the cells of the body, the muscle cells, the intestinal cells, to be converted into energy. However, there's a problem with the gateway into that process. So insulin, which is supposed to help us send them in, is not sufficient enough again. So whatever we want to eat or whatever we want that's going to be of help should make sure that there's much more insulin. For example, the drugs we use, an insulin injection, enhances the level of insulin available. Now, another problem that is also existing is what we call insulin resistance. In such a case, we have enough insulin, but there's some form of resistance to this insulin. So some people actually have high levels of insulin, higher than normal. So in such a case, now we have to find a way to actually reduce the insulin resistance. People with increased adipose tissue, people who are really on the big side, actually have issues with insulin resistance. And that is why weight loss actually helps them control their blood sugar better. Do you get my situation? So we have issue of insulin, and we have an issue of insulin resistance from the cell. So we have enough insulin, but there's insulin resistance. You lower insulin resistance, the enough insulin will be sufficient. Do you get my point? So whatever we're talking about when it comes to food or drugs should work and modify those factors. But I don't know of any vegetable or any fruit that actually does this thing on a mega scale. If you talk of drugs, I'll tell you the drugs that can help. And another thing about fruit and vegetables is that you need to heat them for a prolonged period of time, 3 months, 6 months, before you can actually have appreciable help in whatever they want to give you in terms of vitamins and helping nutrition. I hope I made that area clear.
Thank you. Thank you. I heard you right. Thank you so much.
All right.
Yeah.
All right. So let me move on to the next topic. Eyesight issues. The eyesight issues also came up because we were talking about issues that occurred to us around the age of 40, which is about the time people that don't use glasses before, like me, begin to use glasses, and some other issues. I'm going to be very brief on this because we won't be going into all the details. Whatever we are discussing has to do with changes in the body around the age of 40. Now, I'm basically going to talk about 4 eye conditions here. And the 4 eye conditions are presbyopia, cataract, glaucoma, and diabetic retinopathy. The most important one here, the biggest of all the deals here, is presbyopia, which is what I think I, as a person, am suffering from. It is the normal loss of near focus ability that occurs with age. Most people begin to notice the effect of presbyopia sometimes after the age of 40, sometime before the age of 40, when they start having trouble seeing small print clearly, including text messages from the phone. Now, if you look at the other guy in the image, he's putting the paper afar off to see. And that is what people like me do sometimes when I don't have my glasses nearby and I want to check something from the phone. I have to keep that phone at a distance because I have a problem seeing it at close distance. This thing occurs over time, and it's due to the fact that over time, the eye loses some form of elasticity. You know, the eye is a lens, okay, physics lens, and it's unable to converge much more to focus on near objects. That's why I can only focus on far objects at that point in time. Majority of us will take glasses. Some can go for corrective laser surgery. Some people can go for what's it called, contact lenses to actually correct it, but it is no big deal per se. Another issue that I want to talk about again here is cataract. Cataract is very, very synonymous to elderly people and elderly diabetic people. It's one of the damages that happen in the eye. Cataract can be removed by surgery over time. It is clouding of the eye. A particular kind of sugar, sorbitol, is absorbed into the lens and clouds the lens. So when you look into their eye, you see like a white spot in those eyes, and it can be removed from surgery easily. Now, glaucoma is another big issue, and this is where majority of some form of blindness occurs. Out of all the issues here, or common issues, glaucoma can cause blindness. It's more or less a case of elevated intraocular pressure. What it means is the pressure of the fluid in the eye is very high. Is very high. There's another type that doesn't have that category, but the problem with glaucoma is by the time you realize somebody has glaucoma, there's some level of damage that has occurred in the eye. There's some level of loss of vision that has occurred in the eye. The problem is that that loss is not reversible. That loss is permanent. To make matters worse, even when treatment for glaucoma begins, there might still be some little much more loss of vision in the eye. Eventually, this person might be partially blind before any help can get to the person. So we really advise that if you've had a family history in this regard, or if you can just take a careful look and just go for an eye screening, check the intraocular pressure of the eye to be sure you do not have any impending form of glaucoma issue coming up. Because the problem is that once the damage sets in, the damage is unreversible. And you know, in this part of the world, in Nigeria, people don't present on time when they have issues. They know they have a problem with sight. Since it's not actually killing them at that point in time, they will manage it. Then it gets worse. Then it gets really worse. Then it gets really bad. Then they show up in the hospital. Unfortunately, at that point in time, the damage cannot be reversed. Whatever is left from the vision is what they will have to live with as time goes by. So that is the problem with glaucoma. So the best way to prevent it is actually assessing the pressure before time. And if it's found to be elevated, the individual will be placed on drugs, eye drops, that will actually lower this thing and improve the situation. The last one we have there is retinopathy, diabetic retinopathy, which is actually a complication of diabetes also. Now, pregnant women who have had a bit of diabetic retinopathy, then in pregnancy have gestational diabetes, may have a worsening situation in their eye at that point in time. So when we have a pregnant woman who has had gestational diabetes, it's always important for them to go for their eye check, because in pregnancy, their eyesight might worsen. And like I said before, if the eyesight gets worsened, that damage is not reversible, okay? That's the issue with them. Now, another important thing is risk factors, but we can talk about these risk factors briefly. Who are really at risk of having eye problems, okay? We talk about people who have had other conditions, diabetic hypertension. Diabetes can affect your eye. Hypertension can also affect the eye. People who have this issue have a big problem of developing retinopathy. Family history of glaucoma or macular degeneration. That's also another problem also. A highly visually demanding job or work in a high hazardous occupation. This is work hazard related issues. Health conditions that has to do with cholesterol, the thyroid, anxiety, or depression, and arthritis for which medications are taken. Even some medications can actually have such problems. Now, we do know that sometimes that there are some drugs we give children, but we tell them that don't give a child that is less than 2 years old. Simple drugs like pyridine or phenygal, which is promethazine. Part of the problem we have with them is that the moment they dry the nose, they have a tendency also to dry the eye. And the dry eye is prone to damage, okay? People that don't blink often, they tend to damage their eye because a dry cornea can easily get damaged, and that is a lot of problem in that regard also. So now, just like your body, your eyes and vision change over time. While not everyone will experience the same symptom, the following things are common. Now, if you notice any issue that has to do with that, you need more light to see something, you have difficulty in reading or doing close work, you have a problem with glare when driving, that is when an opposing car has its headlamps on, or you have a change in color perception, or you notice that your eye doesn't tear as often as before, you need to seek medical attention if you notice any of such symptoms in the eye. Now, another popular situation we have here has to do with the use of the eye and the use of computer monitors, phones, laptops. Excuse me. Now, if you in part of the symptom I mentioned earlier, okay, there are warning signs of health problems. If you've noticed anything that has to do with fluctuating vision, you see floaters or flashes in your eye, there's a loss of side vision, that's peripheral vision. That means you can only see centrally, you can't see to the side, or you see that you are seeing distorted images, please consult your ophthalmologist as soon as possible. Now, we also must realize and we also must know that the use of phones, laptops, and computer screen actually affects our eyes. And one has to be very careful the way you do them. First of all, the issue of distance, keeping an appreciable distance from the eye, issues with eye fatigue and discomfort, dry eyes, headache, blood vision, and issues with shoulder pain, neck pain. One has to be very, very careful how we use these screens in order not to cause damage, especially when people that don't blink often. Another group of people, apart from us, that may have issues with this thing are actually children. They tend to use this often in such a way that may damage their eye or cause them to have some form of eye fatigue and discomfort also. Some children may be on the screen for like 2-3 hours and later complain of headaches, complain of inability to see clearly and all that. So we need to regulate this thing. Now, we can't do without the monitor. So we need to find a balance in terms of how often we use it, the distance of the screen to the eye. Do we have any protective screen over it? How long do you sit at a stretch? Are you the kind of person that blinks often, or you are the kind of person that doesn't blink often? Okay. Do you have symptoms you pay attention to, or you have symptoms you don't pay attention to? So all these things are important when you are using your phones and your computer screens. And we also need to monitor our kids if they are doing the same or they are not doing the same. So that will be all for now when it comes to eyesight visions. Thank you very much for your time. Can I have questions, please?
Only ask your question.
Hello.
Okay, why is Dick so serious? Tell her there's no why. There's no exam. My worry, Nick, she test.
I'm just saying.
Okay, so
Mama,
I have a question.
Okay.
First and foremost, before I ask my question, I just want to make a point. All these things Dr. Jimmy is saying, I know them, but I don't want to be proud. That's why I'm not the one taking class. So anyway, the little question that I have, you mentioned earlier the importance of eating balanced diet. Even though some of us are still very unrepentant, we are still going to continue our union and endeavor. But that's another conversation for another day. So I know that growing up, we eat a lot of iru, low-cost beans. And I also know that the guys in diaspora, they clamor for these things when we are going to visit them. So my question is, what is the core ingredients in iru, or core nutrients in iru rather? And is there any other supplement that we can find these things in, just in the event that iru is not accessible? And then we can have that to make up for what we could have done to help improve our eyesight.
Okay. Funny enough, Iru has been, if memory serves me right, Iru has been touted to be very good for the eyesight.
Seriously?
Okay? Yes, it's been very good for the eyesight. Now, the issue about nutrition, my own, I try to follow issues on a logical basis. Now, if you take our African food versus Western food, believe you me, our African food is 10 times, 20 times healthier than the foreign food. Okay, so the issue of demonizing Inyo and Eba doesn't really come into play because first of all, they are starch. At the same time, they are high roughage carbohydrate, which is good for the bowel. They make the bowel move. Do you understand? At the same time, if they are eating in moderation, you understand? If you don't do your Eba like Oreo anymore, you understand? If they are eating in moderation, you are better off. You understand?
Moderation is relative. Moderation is relative.
Well, you know, moderation is relative, but at the same time, there are some meals you see, you'll be like, to your long.
Is it your meal?
So, believe you me, we have, I'll give an example. Incidences of stomach cancer, intestinal cancer, or what we call colon cancer, is lower in Africa than in the West, and it's really attributed to our meal. Because when we eat in this part of the world, it has a limited transit time in the body, and it's out of the system. Because it's high roughage, it moves in the bowel very well. Whereas Western diet takes a longer time to move. And a good analogy I give is this. The only way the expressway can be dirty is if there's go-slow on the expressway. If the expressway has no go-slow, no traffic, there's no way expressway will be dirty. But if the expressway has go-slow, and the reason is this, if from your mouth to your anus, if your food is taking too much time, chemicals in the food will have time to interact with the intestine, okay? Which might possibly lead to colon cancer over time. So our meal, our eba, our inyo, and our fufu, and all the rest are still way better than wheat and flour meals. But there must be moderation. In fact, see, be eba, be kukuba, be kukumeji.
Yeah, no, seriously, I think you are contradicting yourself here. In the first slide, you said we should eat vegetables. Now you are saying that our food digests better. Stick to one. Are you saying that we should continue with our eba in your?
Okay, please, somebody take Ogate to the back of the class.
I think what
to my friends, just wait and go.
Well, so Kule, do we want to? I don't know. We've been here for
see,
about
let's wait to us.
we want to take
how are you?
Presentation, or we want to adjourn.
Want to adjourn.
Exactly. That's what I thought. The Tolulope's presentation is 90 slides. 90.
No. You will not go to that 90 slides. I saw that in a scared for God. I was like, nope, it won't happen. So you can actually pick out, while running through, you can pick out the one you want to.
So how do we proceed? Should we go ahead with the Tolu, or should
we have how many minutes left?
I don't know.
Sorry.
I think we'll be on for like 1.5 hours now.
We have 6 minutes.
We have 6 minutes left. We have 6 minutes left.
6 minutes.
Yeah, 6 minutes.
This time we communicated.
Eré tàǹtẹ̀ lórí platform yẹn ò kú ẹ̀ ṣé eré láti wá
I don't see your faces. Kule is not a serious student. Lere is not a serious student.
I never knew up to you. I never knew until I just saw her now.
Please, I have a question for Dr. Jimmy again. No, please.
Okay.
I also have question
Don't
for
worry.
Dr. Jimmy.
Okay, don't worry. You're okay. Don't fear all these things that doctor are saying.
Dr. Jimmy, how does adequate level of hydration in the body assist in combating what's it called, diabetes?
Well, hydration is another big deal. Timothy is in the clinic that, okay, I'll give you a very funny.
Kọ́kọ́ explain hydration kó tó answer question ẹ̀. Kí ló ń jẹ́ hydration?
Omi mímu ló ń jẹ́ hydration. The amount of water in your body.
Before you explain it, is it minimum hydration, right?
What about one doctor?
Hydration mélòó ló wà ju hydration lọ?
Ṣé wọ́n mọ̀ wé ni? Jẹ́ kí doctor sọ̀rọ̀ jọ.
There's no hydration is hydration. There are no two definitions to hydration. Hydration, you are either hydrated or dehydrated. And it's hydrated there. Emma wa ma sọ science.
Kúnlé ló dá lérú. Ṣé trophy ó ṣe hydration ni? Ṣé bó mi ló wà ní trophy?
Exactly the point.
Ẹ má máa fi ìbú ara búyàn náà, oníkẹ́ máa ní pé ṣó mọ̀ wé ni.
Ṣé wíkẹ́ ìdúgbẹ́kú ló sọ̀rọ̀ ẹ̀? Ṣé trophy ó ṣe hydration ni?
So guys, I want to say something.
Say something.
Say.
Say.
Okay. So
hello.
Don't mind me. I can be saying rubbish, but then it makes some sense.
Let me put it on speaker view for you because you're a speaker. Oh yeah.
Okay. So I didn't hear what you said, Jumo.
I do want to speaker view because you're a speaker. You have a speak.
Okay, so I am so particular about ergonomics. While Jimmy was talking, he made mention about the positioning of the screen to you. So normally there is a standard for setting workstation. Most of us, or some of us may not be privileged to have that, but then you can check it online to see what appropriate distance it's meant to be to you. But normally you are supposed to have somebody that sets your workstation for you. If you are complaining of the high, the workstation evaluator is meant to come and check and see some other things that could impair your seeing very well, which at the long run might affect the high. I have helped people to solve that problem based on what I do, but I just felt like adding it here as a contribution. Don't mind me. Thank you.
Can we contact you privately to be setting up our workstation?
If you consult me, I'm glad to help those that are nearby.
Oh yeah, you have not answered the question, Ojimi, the hydration question. Please. Don't mind me.
I'm supposed to.
You have 2 minutes.
Hello. I'm supposed to take 3 topics. I'm taking.
Somebody asked a question now.
It's still the topic on insomnia and concerning hydration. There are two disease conditions that can arise from inadequate hydration. One is kidney.
You not follow me to the park.
Okay. The second one has people developing hemorrhoids. Now, a lot of time when I see people in the clinic and they complain of hard stool, of the fact that going to the toilet is like going to the labor room, or the fact that the stool was so hard that it sort of had a tear in their anus and they saw blood. You understand? The first thing I question is their water intake. The reason is that the body has a very strange mechanism. You know, we have the small intestine and we have the large intestine. The large intestine is like a bulk mover. You understand? Whenever there's inadequate water in the body, before you begin to feel the first mechanism, okay, the body actually squeezes water out from the large intestine. Okay, so based on how poor your water intake is, your stool can come out like stool or can come out normal based on your water intake. So that's one issue with hydration. The other issue with hydration has to do with kidney stones. When people don't urinate often, this occurs in very cold weathers, or no, very cold weather you urinate because you don't sweat. Very hot weathers, like in Saudi Arabia and all those areas are part of the north. they have a tendency to develop kidney stone because their urine is very, very conk. Very conk urine arises from the fact that the body is trying to conserve water. There's not enough water, so there's conk urine coming out more often. And within this conk urine, somewhere in the kidney spaces called calyces, crystals begin to appear. Crystallization occurs, and that is the genesis of kidney stone. So based on your environment, based on your work activity, sometimes we talk about 3 liters per day. Some people use up to 4 liters per day, but at least we need to maintain at least 2.5 to 3 liters per day of water for proper hydration. This could change based on the weather, okay? Because there's this insensible water loss in which you are not urinating, but because the weather is hot, you understand, you are losing water that is not exactly accounted for. So hydration is a big deal in that regard. Have I answered your question?
I will call you for the breakdown because I didn't understand everything. You were just speaking BB grammar.
I don't think I spoke any big grammar.
Don't worry, you've spoken to me. Don't mind Kule.
I'm sure Kule didn't understand. He was just too shy.
Don't worry, he's referring to something else.
Do you understand?
Something else. Just
break it down. Okay, we can break it down for us. It's not this.
Don't worry, I will call you and break it down for you. Yeah,
break it
down.
Don't worry, I'm not alone. Let Elubeku come out and tell us that he understood. Or Larry. You want it's just his style. Tell us what did the difference between
moderator.
It was not sorry. Kule.
Yes.
So I think just to test the understanding, he said for hydration that water and beer. What category of beer is it?
So to one point, water is 96%. I mean, beer is 96% water.
Okay.
So you can get hydration drinking water.
Dr.
You can get some level of hydration when you drink beer. I stand to be correct. I'm not a doctor, but I worked in the brewery for
What of the 40%? What of the 40% alcohol?
Juwon, please, you have to find a way to move Kunle Abukola Gidigbe in our next meeting, please. They are distracting us.
No, let us educate ourselves. So there are some beers that have 0% alcohol. There are some beers that have 0% alcohol.
Origin zero, right?
Not origin. There's Heineken.
Since when did this become beer lecture? Since when did this class become beer lecture, Kunle?
When you hear beer, don't let your mind get on alcohol. Juwon.
Kule, you are making sense. Kule, you are making sense.
Hello. We know you are trying to tell us.
When people hear beer, their mind immediately goes to alcohol. There are some beers that have 0 alcohol. Heineken has 0 alcohol. Miller has 0 alcohol, and a lot more other beers across the globe.
So let me ask you a question. In the Bible, Jesus turned water to wine.
Oh yeah. I just cannot put it on WhatsApp. About ways later.
I've got to go.
Juwon, please take notes.
All right, let me ask.
Can I take that question?
Okay,
can I take that question on this platform?
My question deserves to be answered. I need it.
I agree with you 200%.
Get about the gates.
I agree with you. Can I take that question very quickly, please?
Please take it.
Okay, so quite honestly, I need to quickly give you a background from the perspective of fermentation in chemistry.
Okay.
In fairness, the process of brewing beer, just like producing wines, goes through or it involves fermentation. There is no way you can produce beer or produce any alcoholic beverage that would exempt the process of fermentation. So if you rewind to Bible days, quite frankly, the wine that Jesus will have turned water to at that particular occasion There is no way on earth that it can be a non-alcoholic wine. It's not possible.
Thank you.
Thank you,
And then
Thank
to give
you.
you perspective, so if you look at 1 Corinthians chapter 11,
Oh, wow.
if you read from verse 20, if you read 1 Corinthians 11 from verse
going to ready you. Kule, serious.
Kule, continue.
Question, oh.
Oh Lord.
Chatilus Kule Abi. Kule Abi.
Thank God.
Is the Holy Spirit at work? We lost Ogate too, Abi.
No, Ogate is still there. It's still there.
Okay. Anyway, Kule, that Dr. Tolu is posting a question on the chat, and should we let Dr. Tolu take his own lectures next week, or what's the way forward?
Yeah, I say next week.
Next week.
So next week we still come back, and then we know that it's Dr. Tolu that will take all the lectures next week.
That's fine.
That's fine.
Thank you. I just wanted everybody to be on the same page for that.
Okay.
Thank you.
How about if the network is not good?
It will be good. Don't worry.
No. Don't say it should be good. We need to work. Maybe you can do a voice note. Maybe you can do a voice note, then it will be shared on the platform, and then somebody will now project the presentation.
Is that for
Dr. Tolu, just in case the network is still not good?
But he's here now.
Yeah, but you can't. He's here now, but you can't get it across to us. As in the network at his own end is bad, kind of.
No, I have the slide though, but time till let me
slide. Then you book 90 pages. I
have the slide. I can share it, but we want to do this now.
No, next week.
Hello.
Yeah, I think next week will be better.
Let's do it next week, please.
Next week is good. Yeah, it's better.
There should be a backup. Maybe Jimmy should go to the slide, and in case Tolu failed to get along to or across to us, then Jimmy can take over.
I agree.
Can we also have excuse me, moderator, can we also have nurses contribute to this, because we have nurses in our midst, and sometimes the nurses are the ones that are actually the nurses are the ones closest to the patients most times. Can we have it like from a nurse's perspective to share? And
of course, why not?
And that's fine then. That's fine. But they should be ready to answer all questions, difficult and simple ones.
They cannot answer you, Ogate. Nobody can answer you. It's only Nika that will answer you.
By the way, recording.
It's only Nika that will answer. Nika Mabandalo.
Ìfẹ́ ṣe o tẹ pí mọ́lẹ̀ ní kí ló dé? There are some nurses that knows these courses more than the doctors do, based on practical experience.
Kule is back. Oh, let's end this. Kule is back. Kule, nice to see you. Bye.
Thank you.
Please share the slide, share the slide, please.
Which slide?
The one that was taken to. Now I missed part of it now. Okay.
No.
I missed part of the lecture for today.
We started for now.
They're not. Hello.
The whole session was recorded, okay, and it's going to be on YouTube. So when I'll send you a link. You can watch everything on YouTube.
English. I beg the slide, Joe.
Now, do you want English also? Send the slide, you know,
network body is stable.
I'll send you the slides.
Ajaja manage you hook up. Ajaja manage you hook up. I bet send the slide, Joe. Nino.
Buki.
So tiri missing Babafa.
Buki.
Babafa.
My share slide the
now you are speaking.
My share slide the
Now you are speaking.
Now, Buki, now there are some things you not see the slide.
Yes, Baba.
I say you. Oh, the next week you.
Do you want me to?
Thank you very much, guys.
Lockdown. Lockdown.
Elubeku
girlfriend.
Not
like that now. Respect the moderator.
Girlfriend me.
The one you know the funny thing.
When the
at some point, we had 29 participants on this platform.
Yeah. Yeah, I saw that.
We had 29 participants. Kí ló dé tí àwọn ọkùnrin tẹ́ wá sórí platform yìí? 70% of participants are male. Why tẹ́ kí n wá fún prayer meeting? Kí ló dé tẹ́ yín ní kí ayé jù Ọlọ́run lọ?
Prayer meeting. Honestly, wait. Or something like that, man. Like it's a Saturday.
Prayer meeting will nobody want 10 years, brother.
Prayer meeting time to love and share. So I don't know. Anyway, next one shall go attend. I promise.
You want president? Talk about what prayer
men ought to pray and not to pray. Only Bible going to pray men.
Some are about free.
Only Bible is going to pray women.
Free.
Money.
The one you love.
Kọ́ ní ìsìn kúnlẹ̀.
Lọ́fẹ̀ẹ́ o, ṣé mo máa gbá free? Ṣé máa kó bàbá mi fún mi?
Special number tí mo fẹ́ kọ fún ní evangelist ojú ajé ló kọ́. Súnmọ́ lọ́rùn o, ọ̀rẹ́ kò lè súnmọ́.
Ọ̀rẹ́ kò lè súnmọ́. Rọ́rọ́ rẹ̀ o, ẹ̀ṣẹ̀ ló mú yapa wá.
Ọlọ́run làjà, kò lè rójú rẹ̀. Ẹ máa wá fún prayer meeting.
YouTube will record you.
Ààrẹ náà ni.
Kúnlé moderator kì í ní fọ́ọ̀n nínú meeting. O ní láti understand yẹn. Moderator máa dákẹ́, a máa rọra sọ, ẹ dákẹ́ o, ẹ sọ̀rọ̀ bọ̀ ìjọba.
Ṣé o fẹ́ pa ni?
Mo fẹ́
pa ni. Ó máa sì kì í tó wáyé máa sọ̀rọ̀. Á sì kì í.
Ìwọ ni moderator.
Moderator wa ló ń dá.
Ṣé o ní kò
tó wá pé ní ìsàkíláwà?
Níwájú kíláàsì rí ni backbencher ni.
Àmọ́ àwọn tó máa jókòó sẹ́yìn.
Àwọn tó wà lẹ́yìn. Àmọ́ àwọn tó wà jọ́ngù. Àwọn lérè àwọn tó máa gbọ́ràn láti jọ́ngù. Jọ́ngù àti wà lérè àti ògbé jọ́ngù ló máa wà. Ní ìkẹ́lẹ́ lè bá mú wá. Ní ìkẹ́lẹ́ lè bú kó wà lẹ́nu kíláàsì.
Láyé olórí kíláàsì ọlọ́run ló mọ̀ bó ṣe páàsì.
Ìkẹ́ni ni ògbé ṣe wá sẹ́nu kíláàsì bọ̀ kò ní wọlé náà. A kàn máa wò pé ṣàbá nìkẹ́ sọ̀rọ̀.
Irú Túndé ń sìn, irú Túndé àwọn ọmọkùnrin iwájú ló máa
dé. Kò ní wọlé.
Túndé òkú jókòó síwájú kíláàsì mi ló wà o. Òun jókòó síwájú.
Túndé àwọn ọmọkùnrin.
Wọ́n pẹ́ sí táìmù yẹn, táìmù tá a wà ní fún gbà yẹn, ó lè má jókòó síwájú. Ìgbà yẹn ó sì fẹ́ ráfíkà díẹ̀, bọ́ ń sìn bàbá tí iwájú wọn máa jókòó sí. Bàbá Jẹ́ńtù.
Ṣèdè náà máa jókòó síwájú.
Bàbá Jẹ́ńtù mà nínú Wálé Akínọlá.
Náà máa jókòó síwájú. Àárín Wálé máa wà. Àárín Wálé máa wà. Rúsídá ni àárín. Kò jẹ́ pẹ́pẹ́ta àárín ló máa wà. Àárín ló máa wà. A kàn máa dá wàhálà yẹn lẹ̀. Wọ́n lè kọ́ orúkọ ẹ̀. Òun náà máa dálẹ̀.
Sọ́jà Ogundele bẹ́ẹ̀.
Iwájú ni Sunday máa wà.
Iwájú ni Sunday máa wà náà.
Iwájú Sunday máa wà tiẹ̀. Iwájú Sunday máa wà tiẹ̀. Mọ kíláàsì olóhùn á ṣe upstand greet.
Good morning. Wọ́n mi ìrojú ẹ̀ mọ̀ kí ló ṣẹlẹ̀? Ṣé kí wọ́n ti lọ ní?
Irú Kọ́lá Wọlé Adélóyè. Kọ́lá Wọlé Adélóyè.
Wájú ló máa wà, wájú ló máa wà, wájú.
Gòkè náà máa jókòó síwájú. Gòkè àgbájọ. Gòkè àgbájọ wájú ló máa wà.
Irú Gòkè
Alpha.
Ẹjọ́ ta ló àti ò sọ̀rọ̀ ẹ jẹ́ kó ó ti ẹ̀yẹ kọ́ introduce ara wọn. Àkọ́ àti ò sọ̀rọ̀ látàárọ̀ ẹ jẹ́ kó sọ̀rọ̀ kó bó ti ẹ̀yẹ kọ́ introduce ara wọn.
Gbogbo wọn ti lọ tán, àwọn just 9 people ló kù now.
Okay.
Everybody don't go now. Maybe we are just 9 now.
Tani Olú.
No, no wonder.
Olu, okay.
Kule, I think we can do our AGM like this, so.
AGM, kí ló dé tó ẹ ṣe AGM báyìí? Ṣáwa ní jẹun ni.
Lockdown, Anita.
Ṣáwa ní jẹun ni.
What's effective now? Use force.
Hi, darling. Hey, she's not a big girl. She's not a big girl. Can you remember you were once in Ilesha, that you came to Ilesha? Oh, what's Ilesha? Nobody want baby.
What do you remember? Tell them.
Africa. That's how she'll be telling her friends later. I'm from Texas. I'm from Africa. Hello, how are you?
You like the uncle? Yeah. What's his name? This uncle.
Àwọn ọmọ owó bèèrè ló kù síbí o.
Túndé mo ti gbàgbé orúkọ ọmọ ẹ̀.
You remember me, right? I remember me. Ọjọ́ iwájú.
Okay. We'll go and buy something.
Your daughter is shy.
Shy Ken, no. Kò shy o. See.
Ẹ ṣàfẹ́ lọ mọ́ báyìí. Mi ti tọ́ ẹ máa lọ lé.
Aláàbọ̀ ibi la máa kú sí. We die here.
Àti wá di wá rí o. Ìfẹ́ ti di wá rí o.
Èmi nìkan lobìnrin tó dẹ̀kù nísìnyí o yẹ wa máa bá tèmi lọ.
All right.
Bàbá mi fún sí dọ́tà ẹlòmí ló ń jẹ straight jọ máa
dùn. Oúnjẹ tó sẹ́yìn dàbí.
Okay, guys.
Oúnjẹ veggies tó sẹ́yìn tàbí. Veggies tó sẹ́yìn.
Family affair ni ẹ na ṣe.
Ẹ̀fọ́ ọ̀rọ̀ tó sẹ́yìn dàbí. Kúnlé afa oṣùn wù mí jẹ. Kúnlé oṣùn wù mí jẹ. Mushroom wù mí jẹ.
All right, guys, I'm leaving you. Enjoy.
Ó tún sí lára veggies tó ní ká máa jẹ ọ.
Ó sùn àti kan ni.
All right, ìfẹ́. Kò sínú veggies tó ní.
Ṣé o ní ká máa jẹ kan ni ṣá? Kan ni àti oṣù.
Ẹjọ́ ẹ má bínú o.
Tó láyé yìí.
Pẹ́pà wà ní Garden of Eden. Pẹ́pà wà ní Garden of Eden. Ṣé a máa ní gbogbo ó diabetic, a máa jẹ fruit steady. Kò tẹ̀ ní ìfọ̀n wàásù fún wa pé ká máa jẹ veggies and jẹ fruit.
Lè ní nà ṣe báwọn the only creature that saw the devil ló fa wàhálà. The only creature that saw the devil one-on-one.
Ọgọ́ mi tí wọ́n kó bá wa báyìí.
Ló fa wàhálà náà. Ọgọ́ mi tí wọ́n kó bá wa. Bọ̀bá ò lò bá ṣe rí mẹ́ka ló wà ní Garden of Eden náà Pastor Kúnlé o.
Mo yẹ ìwà náà ni.
Bí báwo bó ṣe máa rí Garden of Eden tó ní wàṣọ pupa yìí.
Everybody á wà naked. Everybody máa wà naked.
Ọlọ́run kọ́lọ́ wá lórí.
Kò ní sí birth control.
Ṣé wọ́n máa wọn wife máa wà? Ṣé wọ́n máa wọn my wife máa wà?
Kò lè tí wọ́n máa wọn wife náà.
ṣe padà sí lẹ́gùn yẹn. Tí Garden of Eden.
Kò ní tí wọ́n máa wọn wife náà, ṣé wọ́n pé
Ẹni tí wọ́n máa wọn wife náà.
Kò dẹ̀ ní sí pé bóyá à ń tó àbí à ń sọ bride price.
Kò ní sí wọ́n sọ bride price àbí.
Tó bá ní láti attend anybody, wàá tún attend, wàá ní bàbá ṣe lọ.
Ọlọ́run ayé Garden of Eden yìí, bọ̀ wọ́n ti ní kò tí ó ga ọ.
Thank you.
Ibẹ̀ ló yẹ ká wà. Gbàgbé bẹ̀ la wà ń sùn. Gbogbo àwọn tó ní crush fún, bóyá o ní crush fún Rihanna, o ní láti máa ṣe kí ni wàá kàn lọ bá, wàá dẹ̀ attend, wàá dẹ̀ máa lọ. Òǹgò ò ní kà sí ẹ̀yìn.
Ó ga báyìí o.
Kí ló ṣẹlẹ̀ tí ọmọ ìsọ̀fún ga báyìí? Kí ló ṣẹlẹ̀? Kí ló ṣẹlẹ̀?
No, mo ní káláyé Garden of Eden la wà. Kò ṣáà lè ṣe wọ́n máa wọ́n wife náà. Àbí wọ́n máa wọ́n wife ló tún máa wà ní Garden of Eden.
Èmi ò mọ̀ o. Dáṣọ́ra ẹ̀.
Báwo ló fẹ́ sí wọ́n máa wọ́n wife? Ní Garden of Eden.
Make I stop the live stream before YouTube go save all these things.